Complications of spinal cord stimulator placement, particularly with dural puncture and post-dural puncture headache, by Abbas Asgharali, Julie Petro, and Dr. Thomas Simopoulos at Beth Israel Deaconess Medical Center, Harvard Medical School. When looking at complications of spinal cord stimulator placement, these are often broken down into two sets, the biological complication versus the mechanical. Mechanical complications are related to hardware, like lead migration and breakage, and tend to be the primary focus in literature, and can approach about 30%. There is an article by Deer et al. In 2014 that has a nice table with the breakdown of all these complications and the percentage occurrence. Biological complications have received less notoriety in neuromodulation literature, particularly when it comes to dural puncture. Other biological complications include seromas or hematomas, infection, which tends to be the most feared complication, and allergic reactions. For this presentation, we primarily use a retrospective study done at Beth Israel Deaconess by Dr. Simopoulos et al., looking at 322 patients who underwent spinal cord stimulator trials and implants over a 10-year period. So when looking at dural puncture, when can it occur? And this is often at two different points, during the access of the epidural space and during threading of the leads. Of note, we often use a 14-gauge needle for access to the space, which makes dural puncture more risky and can lead to more complications. Why does a dural puncture occur? So the difference in the epidural space along different points of the spine can change. And you have to keep in mind that the level of access of the epidural space varies depending on the target site for pain and lead placement. So things to keep in mind. The posterior width of the epidural space is largest in the lumbar region at about 5 to 6 millimeters, and this progressively narrows to about 1.5 to 2 millimeters in the upper thoracic and lower cervical spine, which leaves a little margin for error the more cranial you go. Prior cryomitochrom studies at T1 and T2 have demonstrated large midline gaps in the ligamentum flavum in up to 21% of cases. And so over-reliance on the loss of resistance technique without actually monitoring the needle depth can be dangerous. When there are gaps or poor development of the ligamentum flavum, this can fool the proceduralist. And therefore looking for a clear loss in tissue that is rather ambivalent in consistency can cause the needle to be advanced too far. Other reasons for dural puncture include previous surgery, calcified ligamentum flavum, and of course an uncooperative patient. One other reason that we will talk about in more detail is the inadequate use of contralateral oblique views on fluoroscopic imaging. So when we talk about contralateral oblique views, the use of a 45-degree CLO view was actually recommended by Dr. Gill et al. For optimal viewing of the ventral interlaminar line at the lumbar level as a landmark for loss of resistance. And a 50-degree view is used at the cervicothoracic level. Lateral views are just not as reliable, especially in the cervicothoracic region. There are no good landmarks in this view to clearly note when loss of resistance will occur. Studies have shown that dural puncture rate can approach 1.4% at these levels when using AP views alone. In the study that we talk about here, it was noted that after CLO was adopted into the clinic, there was no cases of dural puncture during access of the epidural space. This slide just shows us some fluoroscopic images with the CLO views establishing the ventral interlaminar line. And below this, you can see the needle ending at the ventral interlaminar line with lead placement in the epidural space.
This flow chart shows approaches to a dural puncture. A dural puncture can either occur during a spinal cord stimulator trial or during a permanent implant. In either of these situations, the dural puncture can occur with or without the provider being aware of the intrathecal access. If the provider is aware of the event, with evidence such as aspirating CSF or having free-flowing CSF, they have the decision to either continue the trial and access the epidural space at another location or abort the trial completely. Either way, the provider also has the decision to perform a prophylactic blood patch or evaluate the patient postoperatively. In this respect, a prophylactic epidural blood patch has not been advocated in the literature to reduce the risk of post-dural puncture headache. However, in this specific scenario, if an epidural blood patch is performed at the time of the dural puncture, it can be performed in the operating room under sterile conditions and with contrast dye spread for verification at the level. There may also be an undiscovered dural puncture at the time of spinal cord stimulator placement. This can occur if the bevel punctures the dura but no CSF is visualized, or during forceful guide wire or lead insertion. If this occurs and is discovered in the postoperative evaluations, the patient can be managed with conservative treatment or an epidural blood patch can be performed at that time. Conservative management of an epidural blood patch includes fluid hydration, medications including antiepileptics such as gabapentin, pregabalin, and Topamax, and analgesics such as opioids. Occipital and supraorbital blocks may also be tried because of the low risk of these procedures. Also, the patient may be placed in supine positioning, which may be better tolerated, as well as wear an abdominal binder. When considering how to treat a dural puncture, we can consider the natural history of a dural puncture. It is more common with larger needles, Quickie needles, which have a cutting bevel as compared to Whittaker and Sprott needles, which have a pencil point tip, and it occurs in females more than males, and often 1 to 5 days after the procedure. Performing a blood patch at any time has potential risks and benefits. Some of the largest theoretical risks are infection and interference with the trial or lead efficacy. Infection is theoretically a larger risk with hardware in place, and epidural blood patches should be performed under sterile conditions. In terms of lead efficacy, blood has specific conducting properties and theoretically could change the energy delivered by the stimulator. However, the blood patch is usually performed at the level of the lumbar area, and spinal cord stimulator leads are placed in the thoracic area. When the decision is made to perform an epidural blood patch, the clinician should be cognizant of the infectious risks previously described. He or she should then determine the location where they wish to perform the procedure. When performing the blood patch procedure, the location of interest is identified, which is usually the level of the dural puncture. Under sterile condition, blood is drawn from the patient and an epidural is performed at the same time. Once loss of resistance is obtained and an epidural space is identified, blood is then injected and usually is injected until the patient feels fullness in his or her back. Technical aspects of epidural blood patch. Technique and volume can change depending on location. In the upper thoracic and cervical area, the volume is usually 2.5 to 15 milliliters. In the lower thoracic and lumbar area, the volume is usually 15 to 30 milliliters. Timing of the epidural blood patch is also of concern and can be done in the OR or in the postoperative area. Timing of redoing the trial or permanent implant is also of concern. Blood in the epidural space absorbs in about 6 weeks with scar maximum in 2 weeks. Therefore, it's recommended to wait about 4 to 6 weeks before spinal cord stimulator reinsertion.
In conclusion, there is no official protocol in the literature for the management of post-dural puncture headaches during spinal cord stimulator placement, and each case should be evaluated separately. We hope this presentation provided you with information on how these can be managed.